Maishani health. Maishani health.
Today's episode of Maishani Health comes to you from Isiolo County, where we take a look at the role of the National Health Insurance Fund, NHIF, in universal health coverage. We'll also be getting a view from the Ministry of Health Command Center with the Cabinet Secretary.
Access to quality healthcare is a right enshrined in the 2010 Constitution. What is universal health coverage? Why is universal health coverage important? Today, the situation is very different. Many Kenyans are able to access quality healthcare thanks to the government's drive to achieve universal healthcare for all.
Kwa majina anaitwa Angeline Nkava na niko Isiolo. Mbeleni kabla nigonjeke nilikuwa nakaa huko Meru. Mwili wangu ulianzia kudhoofika, nikakuwa sina nguvu, nikitembea nikasikia sina nguvu. Hata nikiwa kwa kazi, nikiwa nafanya kazi tu, nikiendelea na kazi nikaanza kuzinzia, kaona nikizinzia na niko kwa kazi, hata nikitembea ni usingizi tu. Sasa nakuwa na mwili una nguvu. Wakati mwingine nikienda kukonjoa, nikakonjoa magonjwa iko na yellow na nikisikia uchungu. Mwaka wa 2019 nikakuja Isiolo Referral Hospital. Nikaenda nikaangaliwa, nikapigwa picture. Sasa ikaonekana ni hiyo sinda ya kidneys. Sasa ikipatikana nikawekwa catheter, nikaendelea kufanywa dialysis huko. Wakati nilianza kufanywa dialysis, nilianzia 2019, niko na karibu mwezi wa 8 nitaanza mwaka 3. Na wakati nilianzia kufanywa nilikuwa natumia kandi nyingine ya universal. Kwa hivyo nikiendelea na hii ya universal ikasemekana itaweza kulipia hiyo pesa. Sasa nikashughulia NHIF, nikakata hiyo. Saa hii sasa natumia hiyo NHIF. Na mpaka saa hii inanisaidia sababu venye nilikuwa siko hivyo. Niko na nguvu nyingine. Venye nilikuwa hata magoti ingeweza kusimama kuoso, hiyo ilinisaidia sana sababu sisikii venye nilisikia mbeleni. Watu wengi nawaambianga, kawaambia msikae bila kandi. Mimi mbeleni nilikuwa mjinga. Wakati Kirito alikuwa anasema tukate kandi ya NHIF sababu ya kitu inaweza tendeka, mimi nilikuwa nasema yani natuambia hiyo tunaweza kuwa tukikaribisha mgonjwa tukatanga kandi ili tukipata mgonjwa tuende hospitali. Sasa nilikuja kujua ni ujinga. Na naenda kuambia wenzangu, nikiwaambia wenzangu, tafadhalini tafuteni hii kandi ya NHIF sababu ukiwa na sinda inaweza kukusaidia, na sinda inakuja hata kama wewe hujui kitu tu inakuangukia. Kama hiyo iliniangukia na nikapata usaidizi kwa hiyo kandi. Venye nilikuwa nasema ni ujinga tunafanywa, niliona si ujinga, ni mimi nilikuwa mjinga. Kwa hivyo naenda nikiambia wenzetu na Wakenya wenzangu, mtu anjitahidi akate hii kandi ya NHIF, inasaidiana sana. Hata kwa watoto, hata kwa wewe mwenyewe inakusaidia sana. Yeah.
Asante sana, tunashukuru. Illnesses rarely announces itself when to visit, and when it does, it doesn't come with a notice, whether or not prepared, and this takes a huge financial toll on the patient and the family. That's why the solution to this is having health service insurance. The aspiration to equitable healthcare for all Kenyans is guided by 3 core guidelines, that is, quality. Quality healthcare means that medical equipment, medicine and medical personnel at our facilities are all of a quality that meets global standards. Accessibility. Accessibility means that all Kenyans within our borders and at every economic level must be able to access quality healthcare services. Affordability. Affordability means that whatever their income levels, every Kenyan should be able to get quality treatment when they need it. Do Kenyans understand universal healthcare?
So we are still in the streets of Isiolo to get people's views and opinions on NHIF cover. And one good thing about the NHIF cover is that you pay 500 shillings per month to cover for entire family. It doesn't matter whether you have 2 kids, 4 kids, 5 kids, so long as it's your family, the NHIF cover is able to cover you. And here I'm joined by sasa.
Salama kabisa.
Unaitwa nani?
Charles Mereti.
Labda utuambie uko na NHIF?
Bado sijachukua.
Nilipata universal kwa hospitali na pia ilikuja kwa manyumbani. Sasa mimi yangu lakini nilipata hospitalini. Ndio.
Na imekuwa ikikusaidia kivipi na umekuwa ukitumia kiaje?
Universal inanisaidia wakati ninapata shida ama nikigonjeka ama maybe kianguka pengine na pikipiki. Universal inanisaidia kwa sababu silipi kitu. Huko nalipwa napatiwa matibabu bure.
Sina.
Kwa nini haujachukua mpaka sasa?
Pesa kuna.
Okay, una mipango yote ya kuchukua in future?
Yes.
Okay, asante sana kwa mchango wako.
Sana kuwa naye sababu ninajua ni mzuri.
Labda utuambie umuhimu wake ni gani?
Inasaidia kwa malipo kiasi fulani.
Ninayo ndio hii na inanisaidia kwa sababu ninapeana hapo kwa hospitali, ninalipiwa.
NHIF sina, lakini kwa manufaa yake kidogo naijua. Juu ukienda pale OC tuseme una cash, umepatwa na emergency tuseme accident ama kitu ingine, uko na ile card itakuokolea juu utaenda tu as long as unailipia. Ikuwa accredited pale hivyo utashughulikiwa, although hauna cash utashughulikiwa.
Muhimu yake najua sana. Akienda hospitali yote kama hii hospitali ya Jarno ama hospitali yote unasaidia sana watu, lakini vile sijapata nafasi nzuri ya sijarejea hospitali yote, lakini hiyo unasaidia sana watu. Kwa hospitali yote ikienda ni muhimu sana, lakini mibata niko nayo, lakini vile sijarejea hospitali yoyote kwanza.
Those are one of the youths here in Isiolo County who has said actually the benefits of NHIF. Anybody, it doesn't discriminate. So long as you are 18 plus years, you can be able to have your NHIF cover and get the health services that you need.
Maisha ni health.
Maisha ni health.
Maisha ni health. Maisha ni health.
Mimi naitwa Abdi Godo. Na mimi naitwa Muumina Wario na mwanamke wangu. Hii gonjwa nilipata tarehe 1 mwezi wa 1921. Mimi nenda hospitali haipatikani, kila siku narudi. Nikanikula mwili mpaka mwili ikaisha. Kupatikana ni Januari 1922. Ndikasemekana ni shida ni figo. Nikafanya operation. Mpaka sasa niko na dialysis. Niko kuendelea na dialysis. Kutoka mwezi mmoja mpaka mwezi wa 3 nilikuwa natumia mfuko wangu tu ya boma. Sikuwa na kati. Mei tarehe 2 ndio nikapata kati. Kutoka siku hiyo nilikuwa kutoka tarehe 5 mpaka mwezi 2 naanza mpaka hadi sasa naanza kutumia kadi yangu. Na gharama ya dialysis kutoka sijapata kadi nyingi sana. Kwa maana kwa siku tunaoshwa na 9500. Mimi ya kadi ni inanisaidia ndio imetoka mwezi wa 5 mpaka tarehe 2 inanisaidia vizuri upande wa hospitali. Pale ya dialysis kwa ndani inakuwa vizuri. Kwa wiki tunaosha siku 2 si ndio? Kwa wiki tunaosha siku 2. Samani cash tunalipanga na 19000. Sasa tulipi kwa maana ni kati. Tunategemea kati sasa. Sana tuzaidie vizuri sasa. Tuko kuendelea vizuri upande kati. Isiolo referral wanatusaidia vizuri. Tunapata dawa mzuri, madaktari wanatuangalia mzuri. Wanatuangalia vizuri sana.
Abdi's concerns are valid, and for a long time a lot of people across the country have had no access to renal treatment. Actually, since independence, only Kenyatta National Hospital and 2 other public facilities were able to offer dialysis. Stories abound of people who have lost their life while waiting for a long time for their turn to get treatment at their kidney disease.
Time for a fast break, but when we come back, we'll have a panel of experts and residents of Isiolo County as we expound more on NHIF and universal health coverage.
Maisha ni health. Maisha ni health.
We'll be discussing a lot to do with universal health coverage and NHIF, and I'll be introducing the panelists. On my immediate left is Bwana Wario Galma. He's a CEC Health Services, Isiolo County. Makofi kwake. Next to Bwana Wario Galma, we do have Dr. Zainab Gura. She is the Head Department of Health Systems Strengthening, Ministry of Health. Makofi kwake. On my extreme left, we do have Dr. Peter Kamunyo. He's the Chief Executive Officer, NHIF. So all the questions you have will be answered today. Please do have your seats. Karibuni sana.
Thank you.
So we go straight, probably we start with the lady, the only lady on the panel, and this is a representative from the Ministry of Health. Now that we talk about universal health coverage, a lot has happened. Isiolo, we do know, is among the 4 counties that piloted this program. Right now, the rollout across the country is underway. But in terms of assessing the kind of progress made, awareness levels countrywide, where are we? Dr. Zainab.
Thank you very much, Ndimuli. Let me step back by actually saying, what is this universal health coverage? What is the government hoping to achieve by starting off this journey of universal health coverage? And universal health coverage is whereby we would like all Kenyans to have access to quality healthcare, affordable healthcare, where and when needed by Kenyans. So whether you are in Isiolo or in Mandera or in Nairobi, then you should be able to have access to the healthcare that you need, the quality healthcare that you need, and it should not be making you poorer. You should not have catastrophic expenditure. You should not have to choose between paying the school fees for your children or buying food and accessing healthcare. So you should be able to walk into a health facility, access the healthcare you need without necessarily making you worse off. So that is universal health coverage. And that is what government is committed to, attaining the highest level of healthcare that each of you need. Each of you need and each of you deserve to have. So that is universal health coverage.
Okay, if we could talk about numbers probably, how far are we?
Thank you. How far are we? Standing back, this journey, and I say it is a journey. It started in 2013. We started with various components of universal health coverage, and we have various programs that is supporting. And I will start off from when we started health subsidy program, health insurance subsidy program. We are covering the vulnerable households. We are covering the elderly, and there we have the 253,000 households on vulnerable and poor households. We have 53,000 elderly who are covered. When I got the other program is Linda Mama program, where it is supporting our pregnant, expectant mothers, taking them through antenatal care, delivery, and postnatal care. We are covering tuned to 1.2 million every year, and this is a great success because it has also put us ahead in our skill delivery rates. We are at 80% now. These are the gains that we've made. The ANC attendance, just one ANC is over 90%, but at least the 4 which is recommended, we are over 50%, which is a great progress considering where we have come from. So, and when it comes to now, after that, we started the pilot programs. In the pilot, the 4 counties, and Isiolo being one of those counties, we covered 2.9 million people in that, and that was 88% of the population of those 4 counties. I know the CEC Isiolo may give us the numbers for Isiolo, but overall in that. And then we went to now national scale-up. And the national scale-up is that we are expecting this to be implemented across using NHIF as the vehicle for achieving that.
Thank you so much for giving us that overview of universal health coverage. Let's come down to Isiolo County. And yes, probably the national level, the success, she has really expounded on that. But in as far as Isiolo County is concerned, would you say the success level has been in tandem with the nationwide success rate?
Right, thank you very much. I'm not able to say to compare the numbers, but I think we've really felt a very huge success comparatively. As she has rightly said, Isiolo is one of the pilot counties. And during the pilot phase, tremendous successes has been done. One, we were able to register close to 200,000 people at that particular time when the NHIF card was running at the facility level. And during that phase, we were able to establish quite a number of services which has not been there before. For example, in relation to health product and technology, we were able to put in place a Reno unit, which is serving not only Isiolo, is also serving the neighboring counties of Meru and northern side, Samburu, and also Marsabit. There's a CT scan where we engaged a consultant who is able to read within 3 hours. He'll be able to give us a feedback, and the doctors can be able to do diagnosis easily and make any referrals when that is required. The ultrasound, which function very well and address quite a number of referrals, which we use to send them away. And you understand very well that when referrals are made, there are a number of costs that people incur. Apart from the patient, they have always 2-3 family members who will follow. Transport cost, accommodation cost, meal cost, that all has been reduced so much. The other areas that I think we've made a very huge progress, which is a lesson which is being learned by other counties, is in the areas of community health services. We were able to recruit about 760 community health volunteers. We were able to establish around 50 community health units. And the county is also able to recruit about 53 community health assistants who are supporting community health volunteers at the grassroots level. If I may just go further, the work which is being done by community volunteers at the grassroots level, which we call in the TIAS level 1, has made a very big progress, because they do visit communities at household level, be able to talk to the mother, a pregnant mother or a lactating mother, refer a child who requires vaccination, a mother who requires antenatal care to the nearest health facilities, and from there where referrals can be made. So I want to say that, just speaking from what Dr. Zainab said, we've made a progress. Of course, there cannot be, we cannot miss challenges. Yes. And in the way we have been handling that.
And we'll talk about the challenges later. And members of the audience, we will allow you to ask questions, because even as they continue enumerating the successes of UHC, probably you have questions, and you may even question some of the things they say. Remember, tutawakubalia hata kutumia lugha ya Kiswahili kuuliza maswali. Ukiwa na swali, kuna Bentura hapo, but before we get to you, Bentura, because we have Dr. Kamunyo here, the CEO of NHIF, and just listening to Bwana Wario here and Dr. Zainab, it's almost impossible to talk about UHC without mentioning NHIF here and there. So definitely NHIF is a critical plank in the government's plan to roll out NHIF, UHC. Now, as part of efforts to continue with the UHC rollout, because this is a conversation we had on Maisha ni Health. You were there on the very first edition when you were in Nyeri. So this is a continuing conversation. Now, the news coming out is that the NHIF has doubled the number of surgical procedures it now provides its patients under the same cover, expanded oncology benefits for cancer patients, 549 surgical procedures from 292. Kindly just take us through this expansion project.
Yeah. Thank you very much, Indimuli, and it is indeed a great pleasure to be back here again. And it is interesting to answer that question. I would like to dovetail a little bit on what Dr. Gura said here in the definition of UHC, is that universal health coverage, universal first means everybody, yeah? And UHC now means that everybody has access without suffering financial hardship, without somebody becoming poor, without somebody having to sacrifice something to access health. What does this mean? It means that it costs. There is a cost, and that cost can be catastrophic. It can lead people to poverty. Now, UHC is cushioning people against that. And as you heard, Isiolo, we are now in Isiolo, was one of the pilot counties was piloting a certain way of financing UHC, where everybody has access. They were financing it using what we call input financing. So the government was making available the facilities that the CEC was mentioning. You know, the inputs, the commodities, you know, the health technology, the human resource, everything. And then everybody who's registered to go and access services. We had a lot of lessons from that, yeah? And one of them is that in the long run might not be sustainable. And then when you're looking at also the referrals, from here then if you need treatment that's not available in this county, where do you go to? And who pays for that? That is why now we adopted the output-based model or insurance model. Remember, we said medical care costs. So who pays for it? Right now, majority of people who pay is ourselves from our pockets, yeah, out of pocket. And that is what is making us and many Kenyans poor. There are others that the government has sponsored, so the government is paying. But in the long run, even what WHO says, to be able to get to UHC, we must transfer that risk because nobody can carry it. How do you transfer that risk? You transfer that risk by putting together my shilling, your shilling, in the Muli is 20 shillings, and we have a pool, and from that pool, anybody who gets sick is able to get their treatment paid for. And that is where, as you said in Dimuli, that in every conversation of UHC now, NHIF is coming up. Because NHIF, being the National Health Insurance Fund, is where we are all pooling so that we are able now to pay for the services. Now, to get to UHC, because of the question of we've doubled surgical packages, there are three things. Number one is to make sure that everybody is on board. So UHC, and you ask, where are we now? That's a very difficult question, because to get to UHC, everybody must be in. You, me must be in. So, and WHO defines it at 80% of the population. We are still far from that.
Where are we, for example? If you say we should be at 80%,
yes.
Are we at 10, 20?
I can tell you this. So for everybody to be on board, you can see the law that we amended just the other day, that to obligate every Kenyan to be a member, but also at the same time, obligate the government to identify and support those who cannot pay. So if we use that as a parameter, the government already has committed 6 billion for 1 million households. And we know in Kenya, we have 5.1 million indigent or vulnerable households. So it means there we still have a gap of 4.1 million indigent. And indigent is somebody who cannot afford anything, even healthcare. You know, cannot afford basic necessities, including healthcare. Now, on the other hand, I can use the statistics that we have at NHIF. Right now, as at the close of the last financial year, for example, we had just over 14 million households that were registered. However, about half only were active. So if it is half, that's about 7 million thereabouts. If you multiply by 4, then you can tell. So we are still quite far from getting there.
And it would be very interesting to find out from members of our audience, if at all they are aware of such services, such unique opportunities, especially with the use of technology.
Maisha ni health. Maisha ni
Maswali yangu ni kuhusu NHIF. NHIF, wakati tunakuja hospitali uko na mgonjwa, unaambiwa kuna vipimo ambaye hiyo NHIF iwezi shughulikia, unaambiwa lazima ulipie cash. Hiyo ndo swali yangu.
Jambo la kwanza na la muhimu ni ya kwamba NHIF inajaribu kuwa kila mtu aweze kupata matibabu yale anayohitaji bila kulipa ama bila kufilisika. Now, that is the spirit of UHC. But you also remember, NHIF does not own any facility. Sisi hatuna hospitali, we contract providers. Na tunaelewana watapeana huduma ambazo tumekubaliana. na kwa hizo huduma tunawalipa. Wakisha kupatia hizo huduma wanalipa, na sisi kama Wakenya kuna ile premium ama ile contribution tunalipa, na nafikiri sasa kwa kila familia ni 500 kwa mwezi ama shilingi 17 kwa siku, na hiyo shilingi 17 kwa siku ama 500 kwa mwezi is what helps you to get all the benefits that we have put. You know, unapata surgery, unapata matibabu ya dialysis, unapata matibabu ya saratani, ya cancer. Lakini kuna kipimo ambapo kinafika that hiyo benefit haiwezi kulipia zaidi. Kwa mfano, kwa sababu sasa NHIF pays for everything, haina exclusions, lakini isipokuwa kitu kama ICU. ICU huwa ilipi. Sasa hapo inabidi mtu anajaribu kujilipia hapo. Lakini yale mahospitali ambayo tumecontract, tuko na contract 2 sasa, comprehensive contract na non-comprehensive contract. Zile mahospitali, na najua hapa Isiolo nyingi yazo ni comprehensive. Sasa unaingia kwenye hospitali na unatoka bila hata kulipa shilingi moja, na hivyo ndio tunataka kuhimiza hata mahospitali mengi yachukue hizo contract zinaitwa comprehensive. Na vile tumekubaliana, what we've agreed with the hospitals is that we are reimbursing them properly, vile wanaweza kuendeleza hata hiyo biashara yao ya hospitali.
Yeah, concerning the universal health coverage, nilikuwa nauza the factors to achieve the universal health coverage. What are the factors for us to achieve the universal health coverage?
One of the basic factors of achieving UHC is identifying those people who cannot help themselves and for them to be supported. It is the basic one, because if we have all the people who cannot afford being supported, then the rest can be able to take care of themselves. Then you have UHC. Now, even what we have done, because the 5.1 million households who were identified through the Kenya National Bureau of Statistics of 2019, but also now as a mandate also of the counties to be able to provide those names from grassroots all the way to Department of Social Protection, through the Ministry of Health, and then to NHIF. So for us, what we get after all this is done is that these are the people who are most needy, and this is the support they've been given. And I want to add just one thing, is not just to leave it to the government. Also individuals who are able to, you know the ones who are not able in your communities, you can be able to support. And that is the spirit of UHC. The spirit of UHC is leave no one behind.
Kwa majina naitwa Zainab Mose. Swali yangu ni hili. Wakati Universal ilikuwa registered, tuliambiwa itafanya for the last 4 years to come. Sasa hiyo miaka moja. Hiyo wakati tulianza kwenda hospitali, hiyo miaka kuisha, tukaambiwa hii kitu imemaliza kazi. Kitu ya kwanza, wale watu walikuwa wanategemea hiyo card kwa wards, waliambiwa walipe, na walikuwa wanategemea hiyo card. Hiyo card tuliambiwa itasimamia mwaka 4. Swali yangu ya pili, kuna watu wenye ni maskini kama wenda wazimu, kuna wenye hawana watu, watasaidika aje juu hata wao ni wagonjwa? Kitu ya tatu, kuna familia yenye ni watu wenye wako na watoto, na ni watu wenye hawana vipande, watoto hawana birth certificate, na hizi vitu lazima uwe na ID na uwe na birth certificate. Wataingia kwa hii mradi aje?
Daktari na Zainab watanirekebisha, ilikuwa kwa muda inaitwa pilot. Pilot ni kitu ya muda, inaangaliwa kama inafanya kazi. Ikifanya kazi vizuri, inaenezwa. Kama haifanyi kazi vizuri, ina kasoro mahali fulani, inaangaliwa namna gani hizo kasoro zinaweza kutatuliwa, ndio tuweze kuendelea nazo. Niyo ya pili, siku ile tulikuwa tumesajili wale tunataka indigent, wale hawajiwezi, wale wana shida aina fulani. Binafsi mimi nimeenda Isiolo South na Isiolo North. Sijaenda pande ya Oldonyoro, lakini nimeenda pande ya Merte na pande ya Garbatula. Niliweza kuona watu wengi wameajiriwa, particularly those ones who are mentally disturbed, people who have disabilities. Some of them have had road traffic accident, wako nyumbani hata hawasongi. Nimeona wakiajiriwa. Pengine kuna mali huwezi kupata kila kitu 100%. Kuna pengine areas tume miss out, but vile Dr. Zainab alisema kati ya watu milioni 5 na 5.1 million tumeajiri tu milioni 1 na 1,200. Kuna wengine milioni 4 wamebaki. Tunatarajia serikali inatarajia tuhakikishe kwamba wale wengine wamebaki ya milioni 4 wote waweze kusajiliwa ndio waweze kufaidika na hii miradi. Na nafikiria ikitokea na tukibatika tuambie Isiolo imepata tena 20,000 tutaweza kuajiri wengine wengi wale hawajiwezi.
When we talk of indigent, vulnerable population, these are the people we are talking about. The people who do not have mental issues, the people who may not have a fixed support, the people, and the responsibility of selecting indigents is entrusted into the county, because through the county administration structures up to the chief level, up to the village elder level, they can be able to identify. Yes, they can be able to identify who are the people in the biggest need of health.
Okay.
So someone who has mental health issues, definitely, and has no fixed support, and is a vulnerable, is an indigent, really should be the priority for the county to select. And that's why they are entrusted with that. At the national level, we do not tell them who is an indigent. It's them who to identify, using the criteria that has been given, that particular person. And the proximity of the county administration and the health infrastructure in the county helps to identify that person. And I would like to encourage, because we are doing this in phases, and the county will get the allocation, if such people could already be known to the structures, the CHVs, the chiefs, to be able to, once the time comes and the county health departments are going out together with the county health county administration to identify indigents, then they are not left out.
Okay.
Maishani health. Maishani health.
Niko na question ya kutoka NHIF. Hiyo kadi inasaidiana mtu aji, kwa maana mimi ni mtu wa dialysis, sasa ndio niko naye. Inanisaidia mimi peke yangu. Lakini upande wa watoto na family inisaidii. Ikikosekana dawa kutoka hospitali, naomba ende tafuta, nikienda hivi nje nisaidii. Sasa nataka kuuliza nyinyi kutoka hiyo NHIF.
Abdi, hiyo swali ni nzuri sana, kwa sababu the first thing that we say is that NHIF does not have exclusions. NHIF is a family cover. NHIF ina cover baba, mama na watoto hata wakifikia idadi gani. Isipokuwa tu siku wamepitisha miaka 18 ama 14 kama wako 24 kama bado wako college ama wanasoma hatua za juu. Kwa hivyo inakukava wewe na familia yako yote. Na umetuambia kwamba at least unapata dialysis. Sasa ningetaka hata tufikiria namna hii. Tumesema contribution ya NHIF ni kiasi gani? Ni 6,000 kwa mwaka. Na inakava family yote. Sasa mtu wa dialysis, unajua watu namlipia kiasi gani kwa mwaka? Huyo mtu moja tu 1,936. Na alitoa pesa ngapi kwa mwaka? 6,000. Na 6,000 inakava family yote. Hata kwa hiyo familia, kama kila mmoja angekuwa anahitaji kufanyiwa dialysis, kila mmoja angefanyiwa. Na bado wamelipa 6,000. Kwa hivyo hiyo inaonyeshana ya kwamba umuhimu, the importance of you being an active member. Hiyo ni kitu muhimu sana. Kwa hiyo familia, mtu akihitaji kujifungua, mama akihitaji kujifungua, anaweza enda kwa mahospitali zaidi ya 6,000 tuko nayo, ambayo yanakubali hiyo cover ya kujifungua. Kwa hivyo it is very important. Now the hospitals that you can go to are 7,800, karibu 8,000 kwa sasa. Na mahospitali sio ati lazima uende hospitali ya ya, nafikiri hiyo ndio ilikuwa swali ya pili ya serikali. Tuko na contract tunaita comprehensive, ambayo kuna mahospitali ya serikali, kuna mahospitali ya kidini faith based, na kuna mahospitali ya private. Na hayo unaweza kuenda hospitali yoyote ambayo umechagua. Kwanza kwa sasa, kwa sababu tumeanza mambo ya dijitali, kila miezi mitatu unaweza chagua ile hospitali unataka kuenda for outpatient. Alafu inpatient, kulazwa, ni hospitali yoyote ambayo tumesajili, tumecontract. Kwa hivyo ile expanding coverage ndio tumekuwa tunajitahidi kuensure kila mtu anaweza kupata hiyo huduma ya afya bila kufilisika. Na hiyo ni kitu muhimu sana. Kwa hivyo ambia wenzako, NHIF haibagui dependents, haibagui mtoto, mama, kila mtu ako covered kwenye hiyo familia.
Do you have to declare your dependents? Probably that's the question.
Lakini pia lazima uandikishe dependents wako. So usingoje wakati mtoto amekuwa mgonjwa ama bibi ama bwana amekuwa mgonjwa ndio unakimbia hospitali kusema huyu hata ni chumba wangu, ni bibi yangu, ni mtoto wangu. Waandikishe mbeleni. Kwa sababu hiyo ndio pia shida nyingine tunapata, watu wanaenda kujiandikisha tu wakati ule wanahitaji usaidizi. Sasa hapo inakuwa ugumu. Kwa hivyo tunawahimiza kila mtu ajiandikishe mapema, aandikishe watoto wake mapema. Hata watoto ambao wamezaliwa, wakizaliwa siku hiyo wanaweza andikishwa through notification. Na hiyo kuandikisha tumefanya ikuwe rahisi hata kwenye mtandao.
Daktari, mimi swali yangu ilikuwa ni hii. Kwa saa hii hapa Isiolo, mimi sijui siwezi kuambia mwa kaunti nyingine, nakwambia tu Isiolo. Isiolo saa hii wale wako na UHC, wache na mambo pilot, tulitoka mambo pilot sio? Hao wengine ndio wanaambiwa saa hii isipokuwa kulazwa outpatient hauwezi enda private hospital na uwezi chagua. Na kuna wale walichagua naye baadaye akarudishwa kwa district hospital. Na nikakwambia kwamba district hospital ukienda hakuna dawa. Wanaandikiwa wanunue. Hapo ndio ilikuwa maneno yangu, swali yangu.
I will want to link this question to the question on what are the factors of achieving UHC. Kwa hii sisi tuweze kuachieve UHC at the end of the day, ya kwamba kila mtu akienda kwa hospitali atapata matibabu anahitaji bila either kutoa pesa ama bila kuwa maskini zaidi. Tunahitaji kwanza kuwa na hiyo hospitali. And that is the reason, and I'll talk from the national perspective, and that is the reason why we are investing more in building of facilities. And I can tell you from 2018, when the pilot was started to now 2022, there is an additional 1,930 facilities, both from supported by national and county governments jointly. As we say, there are 58 facilities that are being upgraded or built across the country in various counties based on the need. So lazima ukuwe na hiyo hospitali within the 5-kilometer radius uende. Na ukifika kwa hiyo hospitali, lazima upate services. Na hii services sasa ndio hapo ndio tunakuja. Umehudumiwa, hakuna madawa. So it is a responsibility of both the national and the county governments to make sure that kuna madawa.
Asante sana, and thank you once again. A round of applause. Hata nyinyi wenyewe mjipigie makofi kwa sababu ile maswali muuliza ni maswali nzuri. Probably you need more clarity on some of the questions. Let's get to hear what Cabinet Secretary Mutahi Kagwe has to say about this.
I have noted from the dialogue, Isiolo residents took an interest in the services available via the National Health Insurance Fund and the output-based financing model. Zainabu, George, and Abdi raised pertinent questions on the scope of services, accessing specialized health services, procedures to activate and use the service, and validity period and available packages for members. Most of these concerns were canvassed by the panelists as well. Let me put into perspective the debate on the input versus the output-based financing models. It is important for Kenyans to understand the journey to adoption of an output-based model nested under the National Health Insurance Fund. In the pilot phase for UHC in Machakos, Nyeri, Kisumu, and Isiolo, the government at that time catered for all the bills, One had only to identify themselves to access services for free. But this strategy had several drawbacks. We noted gaps in contract enforcement and quality assurance, limited geographical distribution of NHIF approved facilities, several incidences of fraud, ineffective turnaround time for service delivery, non-compliance of mandated contributions and manual claims processing as opposed to e-claims, among other several and many challenges. Based on these findings, we went back to the drawing board. Armed with a new plan, we rolled out the current strategy to pay for indigents and vulnerable households, while those who can pay are mandated to pay. Our desire is to have members access comprehensive care and reduce the out-of-pocket payments for services. This is actually beginning to bear fruits. The Ministry of Health, county governments, Department of Social Protection, and NHIF have so far identified 1 million indigents and vulnerable households from across the country who are now benefiting from the UHC insurance scheme. 253,000 orphans and vulnerable children, as well as some 58,000 elderly and persons with disabilities, are also accessing health services paid for by the government. The Linda Mama program has resulted in over 1 million women enjoying free antenatal and postnatal care services for 1 year with their newborns and healthy babies all over the place. We encourage county governments to raise awareness, to mobilize resources to cater for more indigents and vulnerable households. We encourage them to invest in human resources. We encourage them to get commodities, equipment, and infrastructure, as well as ensure a more functional referral system. Additionally, the ministry is implementing regulations to actualize the NHIF Act of 2022. And we want to thank Parliament for supporting us in passing that bill, which means that there will be mandatory contributions by all Kenyans, which means that we will increase the list of health facilities, widen the scope of benefit based on population needs and health patterns. Currently, some of the additional services available through the NHIF are surgical, dialysis, radiology, mental health, and oncology benefits packages. An active NHIF member can now be able to access up to 6 basic chemotherapy sessions from 4. The mental health package caters for treatment of common and severe mental health disorders, neurological and childhood disorders, drugs and substance abuse disorders. And as I conclude, let me just repeat again that health is wealth. Invest in your wealth today by investing in your health. Consistently pay for NHIF membership and transfer the medical and financial risk to the insurer so that you can focus on saving up for other needs that your family, you and your families need. Kwa hivyo kumbuka, maisha ni health. Invest in your health, protect your life and that of your family.
Register for NHIF. You will sleep better, secure in the knowledge that you and your family will not have to face medical bills alone.
And actually, in Ndimuli, a healthy nation means a productive and wealthier nation that is able to spur its economic growth and ultimately improve the living standard for all.
Definitely. Now, in the coming weeks, we'll be looking at even more developments within the healthcare system. We'll be going around the country, talking to even more Kenyans about this issue.
And actually, we'll be able to witness real stories of hope from the beneficiaries
beneficiaries of these programs.
As we always say, believe what you see, not just what you hear.
Believe only your eyes.
Join us next week for yet another informative episode. My name is Fred Indemuni.
And I'm Bentura Kwamboka, and this is Maisha Ni Health.
I am Asia, knowing things that may not be near, things that might not happen today, but that may happen any day. Try to stay safe. With NHIF, it is your every breath. That means your longer health.
Maisha ni health.